Welcome back to the Deep Dive. Today we're doing an intense high-yield analysis, and this one is specifically for you, the surgical postgraduate. We are going to cut right to the core of parotid gland surgery. We're focusing our entire discussion on the most common thing you'll see, pleomorphic adenoma, or PA. And the mission here is to take all that dense textbook material and, turn it into something you can actually use. Actionable surgical intelligence. We want to distill the anatomy, dissect the controversies, and really solidify the concepts that take you from just knowing the basics to expert practice, both in the OR and for your exams.
And that focus is so critical. I mean, parotid tumors, especially PA, this is high-stakes material. You have to know it inside and out. It accounts for something like 80% of all salivary tumors. It's the benign heavyweight. So today, we're not just listing facts. We're getting into the why, the rationale behind why you must do certain surgical steps and why something like, say, enucleation can have just devastating consequences.
Okay, let's start there on the clinical side. What does it look like when it walks into your clinic? The sources paint that classic picture of a slow-growing, painless, firm, lobulated mass.
Exactly. A patient might say they've had it for years. It's usually preauricular, often in the tail of the gland. But here's the nuance, the detail for the postgraduate. We need to talk about mobility. While it's mobile in most directions, laterally and so on, it is classically fixed when you try to move it upwards.
Upwards. Okay, why that specific direction? That sounds like one of those clinical pearls that ties directly back to the anatomy.
It absolutely does. It's pure mechanics. The tumor is tethered, right underneath the zygomatic arch, a rigid, bony structure. So when you push up, you hit that wall. Understanding that little physical detail, it just elevates your diagnosis beyond it's a mobile lump.
That's a fantastic start. Okay, so now here's where the stakes get higher. When does this slow, benign-looking lump suddenly start screaming malignancy?
Right. This is where you look for the critical red flags. The absolute non-negotiable #1 sign is facial nerve palsy.
Any branch of the nerve.
Any branch. If there's new weakness, new paralysis, you are immediately on high alert. Others would be pain, a long-standing lesion that suddenly grows fast, fixation to the skin, trismus, or skin ulceration. And this is a core principle you just have to burn into your brain. Facial nerve palsy with a parotid mass always means malignancy until you have definitive proof otherwise.
That's a very rigid rule.
Right.
Is there ever a scenario where, I don't know, a deep inflammation or something else could cause that? Or is it really that absolute for the surgeon making a plan?
Well, while you can get some rare transient nerve issues with something like a deep chronic parotitis in the context of a solid mass that's been there for a while, the rule holds. The worry is perineural spread, that the cancer is tracking along the nerve sheath. So you have to operate on the assumption of cancer.
Which means your whole approach changes. The consent, the surgical plan.
And everything. It immediately has to reflect the possibility of nerve sacrifice and a much more radical resection.
So for investigations, I see FNAC, fine needle aspiration, is mentioned as quick. But the sources are careful to warn against relying on it completely. They mention tumor spillage and underestimating malignancy.
Yeah, you have to be careful. It's a piece of the puzzle, but it's not the whole picture. That's where imaging becomes key. And for the surgical trainee, magnetic resonance imaging, MRI, is superior to CT here. It's just fantastic for soft tissue and, most critically, for showing you the relationship between the tumor and the facial nerve. You can't plan your surgery safely without it.
Okay, let's pivot. Let's leave the clinic and head straight into the operating room. This is where that anatomy becomes your surgical roadmap.
It really is a roadmap, and the facial nerve is the main highway. It's the structure that defines everything. It divides the gland's parenchyma into that bigger superficial lobe, which is lateral to the nerve.
And the smaller deep lobe.
And the smaller deep lobe, which is medial to it. And that simple anatomical division dictates every single move you make. Superficial tumor, superficial parotidectomy, deep tumor. It's a whole different ballgame. What's so fascinating is that the entire success of the operation hinges on finding the main trunk of that nerve quickly and safely right where it leaves the skull. And for that, we rely on three absolutely crucial, you must memorize them, landmarks.
Okay, let's go through them, but not just as a list. Let's talk about the surgical utility of each one for the person who's actually scrubbed in.
Perfect. #1, the tragal pointer. This is cartilage in the ear. It points about 1 centimeter deep and inferiorly right toward the nerve trunk. It's your first guide.
Kind of like a signpost.
Exactly. #2, the tympanomastoid suture. This is a small bony groove. You'll find it about 6 to 8 millimeters deep to the tragal pointer. The nerve trunk comes out right anterior and inferior to this spot. This is usually where you feel most confident you found it.
And the third?
The posterior belly of the digastric muscle. Once you find this muscle and you follow its top edge forward, it reliably leads you straight to the main nerve trunk. It's a great deep reference point that isn't bone.
So once you've found the nerve, you've protected it. Now your approach changes based on the tumor. Let's clarify the big three procedures.
Right. For your standard run-of-the-mill benign PA in the superficial lobe, you do a superficial parotidectomy. You take the tumor with a nice cuff of normal tissue, all lateral to the nerve, which you fully preserve. But if imaging shows a deep lobe tumor, you have to shift to a total conservative parotidectomy.
Which means?
The entire gland comes out, superficial and deep lobes, but you are meticulously preserving the facial nerve, every last branch. It's conservative because you're conserving the nerve.
And when do you have to go for the most aggressive option, the radical parotidectomy?
Only when you have proven malignancy, and this is the critical part. If that cancer has infiltrated or is stuck to the facial nerve, then oncology wins. That's a radical parotidectomy. Gland and nerve come out together, and then you have to think about reconstruction, like a cable nerve graft.
We also have to mention a specific challenge, the dumbbell tumor.
Ah, yes, a key one to know for exams. This is a deep lobe tumor that literally gets squeezed through the stylomandibular tunnel and pops out into the parapharyngeal space. You might actually see it as a bulge inside the mouth. Because of where it is, it pretty much always needs a total conservative parotidectomy and sometimes even more advanced moves to get it out without breaking it open.
And that idea of not breaking it open brings us to probably the single most important rule in this whole discussion. The sources are so clear about this. Never enucleate a pleomorphic adenoma. Why is this such a surgical sin?
This gets to the very heart of the pathology. The reason scooping the tumor out, or enucleation, is so dangerous comes down to two microscopic facts. First, the PA often has an incomplete capsule. It's not a perfect little ball. And second, and this is the real problem, it has these microscopic finger-like projections called pseudopodia.
Pseudopodia.
Yes, and they poke through that weak capsule into the normal parotid tissue around it.
So if you try to just scoop it out, you're pretty much guaranteed to be leaving those little fingers behind.
Precisely. You break the capsule, you spill tumor cells everywhere, and the result is staggering. Recurrence rates after just enucleating it can hit 45%.
45%. Compared to what for a standard superficial parotidectomy?
Less than 5%. It's a massive difference, and it's why the standard of care is so rigid. You take it with a cuff of healthy tissue. No shortcuts.
So when that recurrence does happen, what does it look like? And how much harder is the next surgery?
It's a surgeon's nightmare. It's not one tumor anymore. It's multiple little tumor nodules scattered all through a scarred fibrotic mess. The revision surgery is so technically difficult, you need meticulous MRI mapping beforehand to even find all the nodules. And often, because the risk is so high, those patients will need adjuvant radiotherapy after the revision.
Okay, I see a note here about an imaging sign, the lucent rim sign.
Yeah, that's a little pearl. On some advanced imaging, you might see this sign, which suggests the capsule is intact and thick. It can support the diagnosis of a benign PA, but, and this is important, it doesn't change the surgery. You still do the wide resection. You don't trust it enough to just enucleate.
Let's talk about the long-term risk then. The wolf in sheep's clothing, malignant transformation, the carcinoma ex pleomorphic adenoma.
This is why you can't just leave these things forever. The risk is about 2 to 5%. And it usually happens after the tumor's been there for a decade or more. You have to suspect it when a patient comes in and says, this lump has been stable for 15 years, but in the last 2 months. And then they list the red flags we talked about: sudden growth, new pain, or, of course, facial palsy.
And because the prognosis is poor, the management has to be maximal.
Absolutely. Total or radical parotidectomy. Nerve graft, if you have to sacrifice the nerve for clearance, you're doing a neck dissection if there are nodes or if it's high grade, and you're almost always adding adjuvant radiotherapy. It's an aggressive cancer.
Now, we can't just focus on PA. What are the other high-yield tumors a postgraduate has to have on their differential list?
Okay, 3 key malignant ones to know. First, mucoepidermoid carcinoma. This is actually the most common malignant parotid tumor overall. Second, adenoid cystic carcinoma. It's famous, or infamous, for perineural spread tracking along the nerves and for showing up with lung metastases years and years later. It almost always gets adjuvant radiation. And third, remember salivary duct carcinoma? It's super aggressive, but it often has molecular targets like HER2, which means you might have options for systemic therapy, which is interesting. And on the benign side, you have to know Warthin's tumor. Think smokers, bilateral, and cystic on imaging.
Okay, let's wrap this up with post-op. The surgery is done. What are the classic complications, immediate and late, that you need to warn the patient about?
Immediately, you're worried about a bleed, a hematoma, and of course, facial nerve palsy. It's often temporary, but you have to document it perfectly. Late complications are recurrence, a salivary fistula, first bite syndrome, and the big one everyone talks about, Fraze syndrome.
First bite syndrome, that's that crazy, intense pain with the first chew of a meal. That's a sympathetic nerve issue, right?
That's right. The autonomic balance gets disrupted.
Yeah.
Usually gets better. But Fraze, or gustatory sweating, that's the one we can actually try to prevent surgically. It really affects quality of life.
So what's happening there? The nerves get their wires crossed.
That's a perfect way to put it. The parasympathetic nerves that were supposed to go to the salivary gland get cut. Then they regrow, but they mistakenly connect to the sweat glands in the skin over the top. So when the patient thinks about food, instead of salivating, they sweat on the side of their face.
How do you stop that from happening?
You put up a barrier. The key, according to the sources, is to create a physical layer between the raw parotid bed and the skin flap. We call it an interposition flap.
Like what?
Most commonly, a SMAS, flap superficial musculopondeurotic system, or maybe some temporalis fascia. You lay that over the nerve bed, and it blocks those misguided nerve fibers from reaching the skin. And two other quick pearls. Try to raise a subsemass flap from the start, and always, always try to preserve the greater auricular nerve if you can.
Why that nerve specifically?
Because if you cut it, the patient gets permanent, annoying numbness of their earlobe. It seems like a small thing, but they will notice it forever.
So wrapping this all up, what's the big takeaway? We've gone from anatomical landmarks to the dangers of pseudopodia.
The main message, especially for the surgical postgraduate, is that managing PA is all about meticulousness. It's about respecting the tumor's hidden microscopic potential. The rules, superficial parotidectomy over enucleation, careful nerve identification, they're absolute for a reason. To protect the patient from recurrence.
Exactly. Detail and discipline. Okay, so we'll leave you with a final thought to chew on. Given that a pleomorphic adenoma can recur as late as 10 years after a perfect surgery, why is the surveillance for a benign tumor a yearly review for a full decade? While for a malignant tumor, we do much closer surveillance, say, every 3 to 6 months, but mostly just for the first 5 years. Think about what that says about the different biological timelines of recurrence and risk.